Good evening, everyone. My name is Erica Johnson. I co-chair the Maryland ACP DEI Committee, along with Kimberly Atkins. Thank you, and everyone, to co-moderate this session this evening. Thank you all for joining. So for this last workshop in our series of 4 planned workshops sponsored by the DEI committees of the DC, Maryland, and Virginia ACP chapters, the Maryland chapter is going to focus on the role of community-based health education outreach as a tool for advancing health equity. To accomplish that, we've invited 2 partners from a thriving health education outreach program. It's called Cuidate, Take Care Annapolis. Cuidate, Take Care Annapolis was awarded a $30,000 challenge grant from the ABIM Foundation in 2022 for combating medical misinformation. The program arose from a need identified during the early pandemic to share accurate and timely COVID-19 information in the Latino and Black communities in Greater Annapolis, with particular emphasis on the large monolingual Spanish-speaking community in the city. They've since expanded their efforts to include providing information about chronic illnesses more broadly and providing support and resources and access to community-based health education and resources for families in Greater Annapolis through a variety of methods that allow them to meet people in the community where they are, including door-to-door outreach. So we're going to start with the 4-minute video that provides an overview of the program. And then I'll come back and introduce Laura Gutierrez, who you'll meet in the video, and Aaron Lee, both of whom will speak today on behalf of the Take Care Annapolis program, from its conception and early growth, all the way to where the program is now and where the program is headed going forward. We hope that you leave the session recognizing what effective community partnership looks like, understand how health organizations and community partners can work together on mutual health goals for communities, and what barriers exist to the advancement of this type of work, as this may be a point of advocacy for all of our chapters. Mostly, though, we hope you'll leave tonight feeling inspired about the important work that organizations like Cuidate, Take Care Annapolis are doing to provide health education and resources that foster trust in the community, amongst the community. And so I'm going to play a video, and then we'll come back after the video and hear directly from Laura and Aaron.
El programa Cuídate Annapolis de la oficina del alcalde Kevin Buckley es un programa que se lanzó en agosto de 2020 para trabajar con las comunidades marginadas de nuestra ciudad, con la comunidad afroamericana y con la comunidad hispana, que estaban con niveles desproporcionados altísimos de casos de COVID. Tenemos 40.812 personas en la ciudad de Annapolis. De esos tenemos casi 22% de la comunidad afroamericana y casi llegando al 24% de la comunidad hispana.
La comunidad que históricamente ha sido desfavorecida, poco atendida.
Dentro de la comunidad hispana tenemos casi 75% de ellos que son monolingües, que no hablan inglés. Según la encuesta que hemos hecho, nuestro objetivo era llegar a los vecinos que no tenían información, acceso a recursos, cuando todo estaba cerrándose.
Y nos dio una gran oportunidad durante la pandemia de poder ayudar a todas las personas latinas que estaban viviendo momentos sumamente difíciles.
Realmente es un proyecto que piensa desde la comunidad, para la comunidad y con la comunidad.
¿Cuáles han sido las grandes fortalezas de nosotros?
Uno es en la distribución de kits o de pruebas rápidas para el COVID.
Tocar cada puerta, hablar con cada vecino y decirle que nuestra ciudad, nuestro gobierno estaba acá para ayudarlos en lo que necesitaban. Nuestro trabajo era no solo para trabajar sobre la temática de la salud y directamente sobre COVID, lo que preguntábamos a través de una encuesta armada era averiguar sobre todas las necesidades de 3 miembros de nuestra ciudad.
Bien sea de alimentos, bien sea de renta, de internet, de salud.
Somos facilitadores de estos recursos.
Pudimos entrelazarnos con muchas de esas familias que hoy forman parte ya de nosotros también como familia.
Y lo importante de todo esto es que nosotros estamos construyendo confianza entre sistemas como el gobierno, de la salud, de diferentes instituciones.
Esto nos motiva a nosotros a seguir adelante. Sabemos que tenemos que hacer un trabajo de educación y empoderar. Lo hemos conseguido con familias que tienen mucho tiempo que han llegado acá por ser personas indocumentadas. Piensan que su condición legal no les da derecho a acceder a los recursos.
La política pública y el trabajo que hacemos en el gobierno es la forma en que generamos herramientas para la transformación social.
Asimismo, es muy importante para nosotros que esta comunidad sea empoderada.
Este programa fue fundamental durante COVID. Mientras estamos yendo hacia la recuperación y viendo cómo ayudamos a nuestra comunidad, lo que vemos es que es un programa que es esencial para poder seguir asistiendo a nuestra comunidad latina.
Es un gran honor estar nosotros aquí como migrantes, puedo estar en la situación de Venezuela y considero que esto es un gran logro de estar orientando a esta familia como si fuera otra familia venezolana.
Queremos lograr que ese programa se establezca como un programa propio de la alcaldía. Sabemos que es muy necesario porque tiende a derribar muchas de las barreras de las cuales tiene esta comunidad. Y nosotros en ese caso somos un punto de apoyo para esta comunidad y queremos seguir adelante.
Thank you for watching that together. And so now I'd like to introduce our guests who are going to tell us more about Take Care Annapolis and Cuidate. And so I will reintroduce you to Laura Gutierrez, who was part of the original Take Care Annapolis team and is now Director of Small Business Policy and Community Development for the Maryland Comptroller's Office. And Erin Lee, who is the Social Work Care Coordinator for the Take Care Annapolis team. And in this role does case management, resource collection, referral, and outreach, and mental health training on behalf of the team. They're going to tell us a bit more about the program. And after that, Kim and I will moderate a question and answer period. And so during the question and answer period, if you wouldn't mind sending your questions directly to me, Erica Johnson, in the chat. So I'll turn it over now to Erin and Laura.
All righty. Well, thank you for having us. Erin, should I get started on sort of the outline first and then hand it off to you?
Oh, sure. Yep.
Yeah. So just a little bit about the Take Care program. The idea of showing that video, which is very funny to see myself on camera. I hadn't actually watched it myself. The program really began when the COVID pandemic began, right? I was hired 3 months into the pandemic starting, sort of said, at that point, there's this big front page article on our local paper saying 72% of the cases are Hispanic. And I was the new Hispanic liaison in the mayor's office, and it was like, okay, Laura Gutierrez, what are you going to do about this? So, from that, and I think it was like 4 nights of not sleeping, just completely stressed out, thinking this is now my responsibility. What are we going to do for our neighbors? We came up with this health equity action program. And the idea was that we would be doing the opposite of what everybody else was doing, essentially, as people were shutting down and closing the doors. We were going to make sure we were going to our low-income neighborhoods, to the folks who were hardest to reach, sharing information about how to be safe, making sure they had access to, masks, Clorox, like everything that was at that point unavailable. Our Office of Emergency Management had a big literally stocked up on stuff. And nobody had access to that. And we, this is a point where in the stores, there was absolutely nothing. You couldn't find a mask. You couldn't find any cleaning products. You all lived that there was no toilet paper, right? So we created kits and literally started going door to door. But at the same time, we were saying, okay, if we're going to be out in the community, we better start asking what's going on. What are they really living? What are they really feeling? What is the current work situation? What are the other issues that are arising? How can we help? So we created our own needs assessment and started going door to door. We created 2 teams, one that was going to focus on predominantly Hispanic, Latino communities, and one that was going to focus on our low-income African-American communities. And literally just started knocking on doors, presenting ourselves, going at different shifts, different hours of the day, work days, weekends, early morning, 2 p.m. when folks were coming back, or nighttime shifts. So we tried to hit all the different time frames and connect with our neighbors. And the things that we found were quite horrifying, to be honest, very eye-opening on how people did not know about resources available to help them. How there was, I think, a lot of just assumptions of how people were going to get their information that was just not working. And that the method of communication was going to be best if, it was through email or things like that, when people really wanted to receive text message updates. So those were sort of our biggest things, then kids not having access to Wi-Fi. I think these are sort of the general ones that most people knew about. And so we created our Wi-Fi program. We had codes that we were giving out for free for folks to get access to Wi-Fi, helping to get food delivered to homes that needed it. Right? And so that's really sort of the main takeoff of our program. As we were developing it, I think the main thing that I felt so strongly about, and especially as I was meeting more people in neighborhoods, was we have a lot of professionals in our communities, especially in our immigrant communities, that were working at Amazon warehouses or whatnot, and at that point unemployed. So we did a specific sort of targeted outreach and for hiring, where I was looking for, I said, are you a licensed professional in your home country? Let me know. I want to work with you. And those folks we paired with community sort of young leadership that knows their neighborhoods, has their cousins, their aunts and uncles all living in the same neighborhood. And we paired the couples, and it was always had to go out in neighborhoods in a group of 2, and what you called our duplas, our chisoms. And with that group, what happened is that we had somebody who could give this great technical experience, had the information, knew exactly, one of our Freddie, who you saw on that video, is a doctor, 30 years of general practice under his belt. Solimad was our, education expert. She had a PhD in education and had really had done her thesis on Paulo Freire. So the importance of having to teaching through your own experiences and learned experiences with folks that are around you. So she did trainings for the team as well. And that, I think, that's the background I had. So that's how we hit it off. And she was able to really integrate the team and help on that training. And I think Ismenia was also on that video, a lawyer. So we had folks who knew different fields and were able to really tackle questions that, maybe a general normal outreach, the generic sort of job description wouldn't have connected to. And the way that we said it and the way that we pitched it, we were able to pull those folks in. So I think that was one of the things that was really special about our program, and that continues to be special about our program, is that we really focused on that brainwaves. So I think it's in Maryland, there's about 15,000 immigrants that are professionals that are underutilizing their degrees, right? And 7,000 of those 15 are in health professional fields, or in the health field. And so those are a lot of people. That's a lot of untapped potential, all of them probably speaking different languages, that need to be connected, and that could be such a resource for our neighborhoods, for their communities. And those are the folks that we tapped into. And so with that, we really were able to get folks to pay attention to Annapolis in a different way. We started receiving so many calls from folks all over the place, saying, what are you guys doing? How can we do that? Our COVID cases in the Latino community started to drop dramatically. We basically flatlined. We partnered with a hospital and with our health department. They would give vaccines, but they would let us run it our way. We would meet people in the parking lot, walk them through, sit with them in the wait, do our survey and needs assessment in the wait as well, so that we were still collecting information, but we weren't leaving anybody, waiting or checking out the parking lot and saying, yeah, maybe not, I'm gonna move on during the vaccination clinics. And then, sort of use that model. If you are next to your neighbor and you are listening to your neighbor and you are working with your neighbor, then they're going to tell you what they need. And that's how we have to advance, right? That's going to be the approach we have to take. And it's going to be different for each person because each person is different. And there's nothing to do about that, right? We just have to put them at the front of the work. And if we can do that, then we can break through in ways that others may haven't. So that was, I guess, the background to how we got started. That we just decided, we had a $50,000 initial CARES grant. And then we started to get other grants. So the CDC Foundation gave us an important grant to continue the work. And with that, we were able to do a network. So we basically started seeing that as we were connecting with other folks in other counties that were needing support as well. They also, were in even, I would say, more vulnerable conditions than we were in Annapolis, and that we at least were a local government agency. They were, folks of, volunteers at a church or, the running a very small nonprofit that had no connection to resources or didn't speak the language. So we created a network for everyone who was working on the same topics and trying to figure out how to provide access to healthcare for our immigrant communities. And that network was funded and is now housed in Maryland nonprofits. We called it Malbec, sort of as a joke to the fact that I'm Argentine and there is a wine, as you might know, but also the Mid-Atlantic Vaccine Equity Coalition. And now that has morphed into LEA, the Latino Health Equity Alliance, that continues to live and grow. And I think we have about 30 organizations that participate. We have a standing meeting with the Maryland Secretary of Health, Laura Herrera Scott, every 2 months to sort of continue to push her on agenda items that we want to work on, but also to get feedback on what is going on, what is working, what isn't working, how can we, essentially help troubleshoot the Maryland Department of Health now. So those are some of the things on how we started to look forward and how we started to build up the space. Our county, it was pretty great. They took on the program themselves, created the Community Health Ambassador program. I helped to, figure out the budget for it, how many people they need to hire, how they could set it up, how they could not lose the data if they're going to work with nonprofits to do the heavy lifting, but still continue to be an actual partnership and not completely, leaving it up to the organizations they were funding. And that continues. That is now actually part of the health department, the local health department, the Anne Arundel County Health Department. And there are a few nonprofits that are still getting funding for that. So, it's taken off. I think our coalition, the Alliance, now has about 27 community health workers in it. And we started a community health worker network that we just did our first Latino community health worker conference in June. And we had a great turnout, had some great folks who, we had community health workers that were doing some education around things they were learning, but we also had other professionals that were joining from the health fields to share what they thought of as best practices. We had the chair of was Carlos from GW. I'm blanking on his title, but a chair of the community health department, came and explained on, the importance of continuing education, the importance of community health workers being advocates as well. So we just continued down that path and continued to find new ways to connect. I think the mission of always having community first and then networking, and that we're, together we're stronger. That's sort of, if we have those two things as our ejes, as our fundamental pillars for moving forward, that really has helped us to grow. So that's a little bit of, in a moving nutshell, the work we've been doing. And I'll hand it off to Erin to share a little bit about what's currently going on in Annapolis, because I haven't, I left that job about a month ago. So.
Yes, thank you, Laura. So yes, I said we missed it dearly over at the city. But so actually, I just want to do a quick correction real quick. So I'm the social work care coordinator for the Office of Community Services, not Take Care team. Actually, Take Care is actually under Office of Community Services right now, at least according to the mayor's staff. So that's just a little brief, little correction right there. But no worries.
She is currently the interim manager.
Yes, that as well. So yes, social work care coordinator and also the interim manager of the Office of Community Services. And we're a city of Annapolis office that is there actually, taking a lot of inspiration from the Take Care Annapolis team as far as, coordinating resources, doing case management, working within the neighborhoods of Annapolis to find out their needs and to work with them on getting those needs met. Definitely. And just, Take Care team has also been a part of that stretch to get things met in the community. I know right now, Take Care team, we actually managed to keep one of the employees. Her name is Ismenia, and she's also, happened to be a lawyer as well. She is wonderful as far as her connections with the Hispanic community in Annapolis, and has kind of carried the torch, as it would, of health education, outreach, continued engagement. And so that's what she currently is working on right now under OCS. The current plan is, when I did speak to the mayor's chief of staff, just some more details about how things are growing. And when we do have a new Hispanic liaison, they will be taking over that role as far as growing Take Care again, building it up to a separate program. And that will also be with OCS as well, Office of Community Services, because the big thing is to have Take Care team to be a part of the city of Annapolis, have that be a city office, and underneath the city office, I'm sorry. And so just in case, if when a new mayor comes along, because with Mayor Gavin Buckley, this is actually his last 4 years, the program will be at risk for, getting rid of, or, being passed on, or underfunded or not funded. So once it becomes like a true city wing, then that will happen. And so we're very excited for that future. I know that the program itself, like Laura mentioned, has grown, beyond just the small city of Annapolis to a county and state. And I believe even in other states, we have looked at the model and used pieces of it to help address the inequities that were happening in the Latino community. And so just as that part, I was very happy to be just, a part of, Laura's vision and coming in and working with her, and when she was the Hispanic liaison, and then when she then came the manager of the Office of Community Services. So definitely looking forward towards the future, in that, we'll have those same connections, as well as with the Black community of Annapolis, working with the African-American liaison, using the Take Care model as well to address some of the longstanding health inequities for African-American residents in Annapolis. That's also one of our future, goals, and constructing that. And right now, our main thing has been maintaining our educational role. Whether it be with the other new COVID vaccinations, getting the word out about those, getting words out about, seeing your doctor regularly and taking care of that part as well. And that's pretty much it as far as how things are going currently. Definitely a big focus of the Office of Community Services right now has been, part of it, taking care of the mental health piece as well, helping on the mental health side. And also one of the things that Laura really worked on very hard before she left the office was getting resources for Spanish-speaking therapists and psychiatrists. Because as we now are moving, I guess, into the post-COVID, mental health has been such a huge focus for everyone involved. But definitely one of the inequities in Annapolis, in addition to the fact that there was such a long waiting list for mental health resources, but then also mental health professionals that also spoke Spanish. So that was something that, we have collected a list, we have organized, and we are maintaining those connections and relationships in order to keep, the mental health field open, diverse, and most importantly, accessible. And thank you so much. And I see we have a visitor over here. It's very nice, very nice.
We had a little bit of an issue yesterday. She's sick, so she's being a little bit needy of her mother. Apologies.
Oh, she is welcome. Thank you. All right. And so now we will take some questions for Erin and for Laura, and you can send the questions again to me in the chat, Erica Johnson.
So I wanted to start with a question while Erica's kind of fielding questions. Can everyone hear me okay? Okay. So you were talking about, we wanted to talk about how to identify the needs and where to focus the initiatives of the program. And you were talking about how, you meaning Laura, how you divided into two groups, these assessment groups, one with the Latino population and the other one with an African-American population. And my question is, did you identify any unique needs of each population? Did they differ in any way? And how were they addressed? Also kind of building upon that, you mentioned, standing in vaccination lines with patients. And I just wanted you to kind of talk about or expand on identifying hesitancy of patients to receive vaccines and how you kind of overcame any misinformation or hesitancy of those populations for receiving vaccinations.
All right, so you might have to remind me pieces of this question, but so yes, we divided into two groups initially because I was the Hispanic liaison at first, and we have an African American community services specialist as well. So we each took on a team and had sort of similar and then sort of different approaches. So I created a framework. With that framework, we both went off and sort of spun off of that, right? At some point, both programs come back under my leadership, and then when we moved over to the Office of Community Services, I sort of pulled it along and tried to keep it alive, right? So that's to explain that a little bit. Definitely a lot of similarities and a lot of things that were unexpectedly different. I'd say like that the access to Wi-Fi, for example, was one that I thought was going to be, similar across the board, but there was, just about 8% difference in the gap of Latino community had more access and the African-American community had less access. And something in there had to do with folks who were in public housing. And those were a lot of the folks that we were working in our African-American community of Annapolis, which is a lot of our lower income, our housing are under the HACA, the Housing Authority of, and so we have a lot of folks who live in those communities, and those groups had specific barriers to accessing our internet program because of the Comcast and the way that Comcast had already worked with Housing Authority, for example. So then they didn't qualify for that program specifically. So that was a complication that we had to figure out how to work through. There was a lot of difference in terms of how folks wanted to receive information. I'm not sure. I mean, I can send the reports and things like that if that's of interest on sort of the breakdown and differences. I'm trying to remember all of I could pull up the report, I would be able to share all the different things. It's been a while since I looked at it thoroughly. But yeah, there were some unique differences, I would say. The other thing I found was the Latina community had a lot of folks in Annapolis specifically. There's like 80% of the folks we worked with were undocumented and monolingual Spanish speakers. Of that group, I think was like, very high. I think we had like 5% of the people we spoke to spoke both English and Spanish. It was, a very small number. So that when we were asking them information on in terms of, you know, how to access resources, they basically thought there was nothing available to help them, and so they didn't even bother trying to figure it out. And then the difference with the African American community that we kept finding is that we kept hitting our heads against the system, basically. So one was completely excluded, and the other was technically included, but systemically pushed out. And that was the I'd say the biggest and most important difference that we had. Sorry for the kids here. And then the other piece was around vaccinations. What was the question, Lisa?
As far as those patient population, their hesitancy to receive vaccinations, or any mistrust conveyed by those populations in receiving vaccinations.
Yeah. So, and that was the big part of having folks who are doctors from the community. So there was a trust built, and there was, you know, just the fact that we're speaking the same language, that we know each other as neighbors. And the fact that, let's say Freddie, in the case of Freddie, right, he didn't live in our city, but he was partnered with Ingrid, and Ingrid knew everybody in the city, right? So she could do an opening of the door, she could introduce, and then he could share from the same sort of perspective. And you know, it was just very, you know, the doors were already open, and folks were open and receptive to hearing what we had to say. I think when we didn't do that, it was different. So it was a different reception. So even, you know, when we partnered with Luminous Health, and we would have their nurses and doctors show up, and they were not, you know, from the, you know, not part of the community, then that was different. That was very different. And we would, you know, it would take a lot more effort on our part to not just have a, hey, like, come check out our, you know, health fair. Come, you know, let me keep walking with you, keep walking with you, like keep pulling you in. So it took a little bit of extra effort in those cases. Yeah. I'm not sure if that answered the question.
It's a our next question is from our governor, Dr. Colleen Christmas. She says she loves the work that you two are both doing, and thank you for sharing it with us. Erin, you mentioned a concern that inherent in much of the work done with government funding, that the funding can kind of just disappear at any time. And Colleen wanted to know, how do we create a program that can weather that kind of change, or maintain some sort of semblance of services when elected officials change and have different goals? And she stated, certainly abruptly ending would breed mistrust in future programs. Kind of building on that question, how can we be better advocates to support these kind of initiatives in our community, especially in our DMV region?
So one of the things that the Office of Community Services, that actually faced something very similar as Take Care, that when the current mayor, you know, moves on, finishes his term, this same office could then be gotten rid of by the next mayor at their whim. And so what happened is our office was actually written into the city code, and that it basically helped secure us. We became a city office that helped secure. And the same thing will most likely happen with Take Care. And that's may happen, you know, to programs similar to that, you know, either getting it written into the city's code, it becoming a city office. That does offer some extra security. Funding, that's a great question, because that's something that I think we all struggle with. There's just this limited amount of funds. There's a limited pot. I found that when people directly address your representatives, whether it be your alder people, your senators, representatives, let them know about the programs, let people know, you know, what good they've done in the community, lobby for them, you know, write your emails, call. I found that to be one of the most effective ways to make sure programs not only get funded, but stay funded and stay around. Because sometimes if you're quiet, you go under the radar, you don't really get any reports. You kind of just, you're like, and then the new person comes in and like, well, why do we have this program? No one's really talking about it. We don't really see the results. No one's really, you know, speaking up about it. So why have it around when cuts come? And I'm sorry, what's the next part of the question?
I'm still muted. I apologize for that. You basically answered the question, but the second part of the question is, how do we create a program that can weather that kind of change or maintain some sort of semblance of services when we're under the threat of funding being cut?
Yeah. And creating that kind of program, that's also a very good question. I'll be in that part as well. I know I probably did answer part of it as far as, letting your representatives know and, advocating for those agencies as well that are doing that kind of good work. Also, I would say increasing grant opportunities as well. I know that, ABIMF, you guys have a grant opportunity that's wonderful. And we were able to, fuel this program through that and reach more people, which we are still thankful for. Just more programs like that, because I know back when I used to work at a nonprofit before working for the city of Annapolis, one of the big things that we came up against a lot was that you had these multiple agencies vying for that same very small pot of money. And you had some really excellent agencies that unfortunately, just for one reason or another, just could not secure that grant funding and unfortunately had to close their doors. And so just, I would say, better accessibility to the to grants, making more of them if possible, reaching out to some of the smaller communities, like, for example, Office of Community Services. We happen to have 2 different grants, and our goal is to utilize and work with small nonprofits that are city-based and community-based. And so looking for programs like that as well to fund.
So can I just jump in and add a piece is that, and I think, this was why we created that PSA, actually. As you can see, there's about 25 views. We never actually shared that except with prospective funders and with essentially our city council to create some pressure, right? And so when you were asking about how to help, even just this invite helped to get that question up again with our chief of staff, right? And hey, so what's going to happen with the program? And, now Laura's gone. Is there going to, are we going to continue to fund it, or because the program was completely fundraised, right? And we didn't use city funds for it at all. We used outside funds because we thought it was important to do, and we, invested in that. But we couldn't get the city council to fund it, right? So helping to educate legislators on the importance of health education and outreach, and having that as part of our government, and having that centralized through government is a whole ballgame, right? They don't even think about, is the reality. And a lot of folks, you might be lucky if you have one person who comes from the health field that's a legislator. So there's a lot of education that needs to be done there. And that's how you get them to prioritize funding, prioritize continuing programs, codifying programs, right? So I think it really starts with them and those conversations, and continue to ask questions. When you put people on the hot seat, it works. There's a reason people don't like to be called out, and there's a reason that then they act quite quickly. So even op-eds, things like that, sharing the importance of that, and tying it to something local, right? Then that will always, you can talk about what's going on across the country, but if you take example.
I think we lost her.
I got cut off. Zoom isn't liking it.
Did you want to finish your comment? I'm sorry.
Yeah. So am I back? Sorry, I wasn't sure. I was just saying, we can talk about things across the country, right? But when you provide a local example, like, I can say I work in the state of Maryland now. I talk about things. But when I talk about what's happening in Annapolis, my community, then that creates a pressure on Annapolis, right? So if you tie it to those local cases, that creates the local pressure to act.
Thanks, Laura. We did have another question, and it's directed at both of you. So whoever wants to respond, feel free. What is doing this work like for you? Perhaps in contrast to prior work you've done, how does this line of work impact you differently compared to your prior work?
Sure. So before coming to the city of Annapolis, I actually worked in Baltimore City and also in Washington, D.C. as well. I worked in therapeutic foster care in Baltimore City, and then also with working with seniors in D.C. So definitely the biggest change was having that more community-based, community-focused work. And that I think was very rewarding because you could definitely see how your actions were based on what the community wanted, not something coming from on high saying, well, this is what they need, that kind of thing. So the dynamic was definitely shifted. And that definitely affected my work, going forward. And that making sure that, any programs that we do will be community-based and community-led, that when we work with residents individually, whether it be for case management, which is something that I've done before too, is that, we work based on what their needs and what they would like to see or what they're looking for. And, but also it's also been just very fulfilling to see, folks, make that independent decision. They, and once they learn better, like they do better, they know better, and they spread the word, which is really nice. That makes things, I would say, so much easier.
So I'll take a stab at this too. So before this job, as if I'm still in Annapolis right now. But before the Annapolis work, I was working in Argentina in the Ministry of Social Development, and I was creating programs with the popular education model throughout the country, and so that was, I would say very top down and at the same time very periphery center to center, and it's we had a very clear vision of what we needed to do, but at the same time it was all about local empowerment. And when I started in Annapolis, the difference of being able to say, we're going to do this, but we're going to do it right. We're really going to do this from the peripheries in. And then we're really going to take our neighbor's word as our direction. That was a game changer. And it was freedom to decide on how to advance. And, we have the pro of not having use government funding within government is that we really could do what we wanted to do with this program. And we could seek the partners we need to seek for it. So there was a lot of freedom in that space to decide on how to move forward, where we were saying, okay, this has no parameters. This has no, nothing, legislated. We are doing this because it's what we are hearing from our neighbors that they need. And that as a driver was the biggest difference for me. And frankly, just it makes you completely passionate about the work, and it's not something, you go home, but you continue to focus on that and live it and breathe it. It's just very different model of work. And then the other part is that our team dynamic, which is truly spectacular. I think, we had and have, it's still a team still there that really trust each other and care about each other and have each other's backs. And we all are like-minded and have, we worked on the training programs we wanted to have for sort of how to do frameworks of community health. And I sort of created my own program, which we did with all the community health workers in our network then. So we did a 6-month training program that was just around frameworks for community health education, how to do proper outreach. And I think, and then we did all of us got psychological first aid training, specializing on how to work with immigrant communities and refugees. And so those different things that we had sort of, I would say, unified us in a way, and we just were sort of offset. We were different than the rest, right? And had a different approach to it. And I think that, and that was noticeable, right? That's how we all became the Office of Community Services too. Yeah. That it's not casual that we ended up there, and there was a reason behind it. So yeah, those were the key differences for me.
Well, I think we have time for one more question before we have to wrap up for the evening. We wanted to know, are there any particular skills that health professional trainees can learn now that will enable them to be able to work more effectively in community-based partnerships? And even for not people who aren't training, health professionals like myself in a primary care setting that may not be knowledgeable of programs that are out there to become involved. How can we become involved if in fact we want to become more involved in community-based initiatives?
I think that's a really good. I know Laura just mentioned psychological first aid training, and I was thinking that'd be a great way to start, especially when you're working with communities that have gone through either traumatic events or that might be actively experiencing trauma. That you work one-on-one with them too, and it's a great model because it actually helps you to talk with the individual one-to-one. You don't need a mental health background or previous training in order to do psychological first aid either as well. But it definitely does help to get the person, individual, more grounded, to find out what they need, how can those needs be addressed. And I think that'd be like a great first training. And then also, and I'm sure everyone's probably talked about this or had training, but active listening is also a very good skill to learn, to brush up on, to understand, because nothing, I'm sure as you guys know, nothing makes a client or a customer or anyone more angry when they feel like they haven't been heard. And being heard, being understood. I know for myself, for example, I don't know that much Spanish. However, I also use a translator. I use the translator app. Laura's laughing because she knows. I use my translator app and we work it out. But I know that, I've...
And my first, our team was...
yeah, and
our team was fun, and that half of us spoke English, half spoke Spanish, and only a few were bilingual.
Yeah, exactly. But it's like that difference, we were able to understand each other, and we came to an understanding, and having that patience, listening helped out a lot. And also having that shared goal of, we are doing this to help the community. This is not about ourselves. It's about, the broader community and improving it.
A general sort of training is on cultural competence, right? That's an important one to have. And then popular education. I can't stress enough how much that changed me in my whole mindset. I went to UPenn for college, and I had a very different idea of how life would be and how life should be. And then I started reading Paulo Freire, and then I got all this training on popular education, and it just changed everything for me. It really turned my world upside down and inside out, and made me want to do completely different things. So that for me was the changer, and I think that could be really helpful for folks. And it also just teaches you a general new way of life and how to educate, how to relate to others. And then, our frameworks on outreach, hey, we can always do that for anybody. I have it written up, so I'm happy to share that. I think it's all in Spanish, but I could definitely share it if that's of interest. And maybe there's somebody else who would want to take it on. Yeah, there's a lot of different opportunities for continued education, right?
Well, we're going to close it up for the evening. I and Erica, we want to thank you two so much for joining us this evening. You responded to our inquiry so quickly about participating on short notice and remained in communication with us, and we're eager to do this presentation, and we're very happy to have both of you. We're definitely hopeful. Hopefully there can be, future collaborations going forward. Erica, did you have any additional comments for the evening?
No, just I echo what you said. Thank you both so much. I feel like I learned a lot of pearls today, and in terms of thinking about, in particular, what we can do to advocate for support for programs like this. And then also I learned some new trainings that I don't have that I probably need to get very quickly. So thank you.
Thank you, everyone.
I'll
for
send
joining.
some Coursera ones.
Yes, we never receive that, and we will share with the chapter. So yes, please do.
Thank you, everyone, for joining us this evening. Have a great
Thank you so much for having us.
Yes, thank you so much for having us.
you.
Honored to be here. Thank you.
Thank you.
Thank you, everyone. Enjoy the. Thank you.